opportunity for me to talk about health literacy with the World Health Organization. And what's the purpose of this? It implies that the achievement of a level of knowledge, personal skills, and confidence to take action to improve personal and community health by changing personal lifestyles and living conditions. And this is important. It's just not passing on information for the sake of passing it on. Now, health education aims to influence individual lifestyle decisions, but it also raises awareness about the determinants of health. And it's achieved through methods that go beyond information diffusion and requires interaction with the individual, participation, and critical analysis. Health education must lead to health literacy, which then empowers individuals, the family, and the community. And it goes beyond the narrow concept of health education and individual behavior-oriented communications, and must address the social, environmental, and political issues. It also is a tool for empowerment, and it empowers people to take control of their health by helping them to properly use the information provided to them. This leads to personal and social benefit, enabling community action and contributing to social capital. And so we believe that it's a means to social and human development, as was outlined by the speaker, Stephen, who talked about the Millennium Development Goals. By improving people's access to health and information and the capacity to use it effectively, health literacy is critical to empowerment. And more than, it's just not about reading pamphlets and being knowledgeable about that, and in order to have this kind of an effect, you need to have a very effective and efficient communication strategy. I'll outline some of the challenges which we face today. The health literacy level is low worldwide, and there are two sides to the coin. One is there's a low level of information, but there's also an overload of information. Let's start with the low level of health literacy. Low level of literacy means that they have less access to internet and online information. They may not be able to evaluate all the quality of information from the different sources. Also, these kind of people have lower utilization of preventive services and tend to use the treatment services more, thus burdening and having an economically high cost for the healthcare system. The other side of the coin, there's health information overload on the internet, but there is lack of enough evidence-based information which is easily available to the general public, and it's difficult for consumers to understand and evaluate the accuracy of all the information they have. There is no standard quality check. Any kind of information is available. The level of health literacy in many developing countries is unknown, and this is very unfortunate. You may hear later today that there is a European health literacy survey which was done, but it's only for the European countries, but mostly in Africa and Asia, there's very little information on health literacy. And also some of the challenges are language barriers, which we're all familiar with, and cultural issues which need to be taken into account. Now I go on to see what are some of the strategies which can be used for effective health literacy. Communication action should be the key component of what we do in health literacy. And in order for that to be helpful, we need to have a well-functioning, rights-based, patient-centered healthcare system. The third aspect is that we need to have multi-sectoral collaboration at the national, regional, and international levels to be able to overcome the inequities, and I'll give you an example of that. This graph shows the gap in non-Maori and Maori life expectancies over a period of 55 years in New Zealand. And as you can see, in both male and female, the gap was quite high, about 14 and 16 years, and came down by half in over 50 years, but still the gap exists. But in order for that to be achieved, the government had to take some serious whole-of-government approach, policy approaches, very strong leadership from the Ministry of Health, and increased expenditure in health services, but most importantly, local intersectoral actions. It was actions taken for the Maori, by the Maori, and this was important to have this kind of drop. We also need to have universal access to health services, which will ensure that all people have educational materials available to them. And education programs need to be not only from the health sector, from the clinics and hospitals, but it also should be in other places, such as schools, colleges, workplaces, libraries, which are institutions that can offer programs to increase public health literacy rates. And finally, we need to have innovative and proper use of ICT technology to bridge the health literacy gap and pass on the information using the new tools which we have available today. One example of that is the M Health Tobacco Cessation Project, which is a program of WHO along with the International Telecommunications Union, where they use mobile phones for awareness of risk factors, screening and citizen reporting. These SMS-based services have also shown that it can be very effective in reducing the number of smokers quitting, and in a publication in Lancet, it was said that in 6 months, the quit rates were doubled as compared to the control population, over a group of 5,000 people who were using these interventions. I now want to talk about the non-communicable diseases program. Again, it was alluded to by our previous speaker. This is one of the highest burdens today. More than 60% of the burden is due to non-communicable diseases. And it's not a developed country issue. It is a developing country issue, more a developing country issue, because the number of deaths from people less than 60 is much higher in the developing world as compared to the developed countries. And therefore, most of this can be prevented. And this is the reason why last year, for only the second time in the history of the United Nations, health issue was discussed at a high-level summit attended by the heads of state. And there was a political declaration which needs to be implemented in the coming years. Yeah, empowerment using mobile health can be a very easy way to go. We can harness the technology to provide sustainable, scalable, cost-effective solutions for key NCD risk factors. Text messages can increase for the use of people using sunscreen. It can improve the compliance of management of diabetes. It can encourage the use of condoms, and they can use sensors and mapping in order to track use of inhalers by asthmatics. So there are many, many mechanisms by which we can use mobile technology. And all of this is intended to have a constant application of the message so that we can have behavior change initiatives through these mechanisms. It's so difficult to do face-to-face communications on the same issue, but I think sending a text message or an MMS will be fairly easy. Now, why is mHealth so important? As you can see in this graph, this is statistics from the developing countries. The reach is so much vaster. If you use hospital beds, it reaches only 11 million people. If you use computers, it's 305 million people. If you use mobile phones, it's 2.2 billion. You can see that the outreach is dramatic. In February 2012, BBC stated that the mobile devices will outnumber the number of humans this year. But interestingly, 2 out of 3 mobile phone users are in developing countries. And if you look at the people in the rural areas, 50% of the people have mobile phones. There's an ubiquitous outreach of mobile phones, and today the global coverage is 7.4 billion, and in 2016 it's expected that there will be 10 billion mobile connected devices around the world. Why wouldn't we use that technology? Let me give you an example of how it is being applied in one of the villages in my country, in a state called Bihar. There's a program called ComCare, where mobile phone application is used as a tool for counseling adolescent girls and on menstrual hygiene, on STDs and family planning methods. This is a rural development program program undertaken by the civil society but supported by the Ministry of Health. We think that people in the rural areas are disempowered and helpless. It need not be so, because they can be reached. There are a couple of examples here of health literacy in action and what it can actually do. One is on a breastfeeding program in the Philippines, where there was a national plan for information campaign on promoting breastfeeding. And this not only increased the breastfeeding, but saw a decrease in infant mortality rate. Another one is on malaria in 8 countries in Mesoamerica, where there was a national environmental campaign on community cleaning of neighborhoods. And this was to keep the environment clean without the use of DDT. So in the homes and patios and surroundings, people cleared the collected waters and covered the water storage containers and managed the drain systems. And they organized community cleanings in the neighborhoods, including the streets and the forest areas and the swamps. What it saw is that in 2 years there was a reduction in vector density and a 63% reduction in malaria cases. The reason why I'm saying this is that these need to be tracked, and we need to have good measures. Without measures, we won't be able to track this activity. Lastly, I'd like to show some of the WHO activities on health literacy. As I said, we do work with many UN partners, ITU being one of them. And we launched in February of this year a National E-Health Strategy Toolkit to help governments to develop their e-health strategy. And each government needs to do this. It needs to be an action plan with a monitoring framework, and WHO assists the governments to do this kind of health literacy plans. This is one of the models of our e-health infrastructure. It can very quickly access health information, but also provide and manage health and well-being by monitoring and managing the medications. You can access the records, the personal records or medical records, and it can also have automated dispensing of medication, pharmacy services. And lastly, there can be an interaction with the care providers and remote monitoring. So this is a kind of a system which can be built, and this is one of the models that we are using. I want to say that also our regional offices are very closely involved in this, and in the case of our European region, their programs are very much empowerment focused, and there are 3 programs which are in this kind of a strategy. One is the NCD prevention program to supply information and tools to prevent and manage NCDs. Another one is on a new mental health strategy, where the heart of the strategy is to empower people. And a third one is on patient safety, focusing on patients' rights and safety around the need for blood transfusion and hospital infections. And all of this is that we need to avoid this kind of a situation where people are not baffled by the numbers we provide, that they can have a better understanding of what we're talking about. Thank you very much.